So vismodegib, metastatic or locally advanced basal cell, sonidegib, only locally advanced basal cell. Of course, we know that metastatic basal cell is very, very rare. But in your mind, Todd, what does locally advanced basal cell mean?
That is an existential question. The locally advanced term is a construct of pharma. Basically, these drugs have been, the Sun is not the original marketer of this medication, not the original developer of this medication. So I think when it first kind of came around, people were looking for something to say, to define what a, sort of more advanced basal cell carcinoma is. And we still don't have a clear definition. So when I think of locally advanced, I think of a tumor that is not amenable to surgery and or radiation, but mainly surgery in such that the procedure itself would carry a risk of morbidity to the patient that might not be acceptable, right? So, you talk to a surgeon and they'll cut anything off, right? They'll cut our heads off if they have to, right?
Yeah.
But the bottom line is that what we really want? Are the adverse effects of cutting your head off going to be appropriate? So when you think of a tumor that is not something, that you say, hey, maybe we shouldn't be cutting on this right away, that's when I think of locally advanced. So you can define that further into a large tumor. It can be defined as tumor with high risk factors, such as perineural invasion deeper structures, bone, cartilage, muscle, things like that. When basal cells get big, they can pretty much invade it. Anything. It's just, usually it's local. Like you said, metastatic is rare, but locally advanced, it can eat into any tissue it really wants to. So that's what I think about there. And I also think about one other category, and that's multiple tumors. So you think about patients that walk in on a Monday morning, have got 7, 8, 9, 20, 30 basal cell carcinomas of different sizes, or maybe they're clustered in an area that makes it, I don't think we're going to spend the next 5 years cutting on this person, right? Yeah. So another category to think of is multiple tumors.
Okay, great. Thank you. And these are, I don't know that we've mentioned it, but these are both oral drugs, right? These are pills that you take. These aren't infusions, much like the PD-1s are infusions. These are pills. And they're supposed to be taken daily, but from what I understand, Todd, decreasing frequency of dosing and or taking breaks is pretty darn common because of the adverse events, which muscle cramping, it sounds like, in lack of appetite or dysgeusia seem to be the top 3.
Yeah, those are the most common things. Muscle cramps, weight loss, dysgeusia, as you'd mentioned, loss of taste, fatigue is up there as well. Those 4 are the main ones that patients will probably suffer from. And you mentioned a very important thing, which is alternate day dosing. So the vismodegib was studied in a study called the MIKIE study, which we participated in. It was a phase 2 study that was probably the 15, 16, 17 timeframe, maybe a little earlier in the early 2000s. And that study was designed to look at just at that, because people were doing all kinds of different things with dosing. We still do, right? The whole point is, can we keep the patient on the medication? Because we know these drugs take several months to work. Fortunately, the beneficial effects, the efficacy usually precedes the development of adverse events. So, if you could get people on the medication and keep them on long enough to start seeing a benefit for their tumor, maybe they'll tolerate the adverse event more than they would like if they weren't getting a response. So out of that developed the MIKIE study, which was looked at 2 different dosing regimens of vismodegib. And the whole point was to determine whether like an 8 or a 12-week break between dosing would, and I can't remember the exact categories, but they had 2 arms, and one had a shorter break, one had a longer break. And they ended up coming out relatively similar. The efficacy wasn't that much different if you gave the patient a break. So if they maybe went on for 8 weeks and then took a 4-week break, or they went on for 12 weeks and took a 4-week break, they're pretty close. Like, I don't think even statistically significant, but the adverse events were better. So that's one thing that came out of that. And there's another study called the STEVIE study. The STEVIE study was a global large safety study for vismodegib, and that was a kind of concurrent or around the same time. And the STEVIE study was all about adverse events. So what it told us is that if you've got adverse events early on with these medications, if you were able to stay on it, they would fade. So sometimes hair loss would get better over time. So those were important studies for us to understand what the short and long-term safety profiles are for these medications, so we can really, the goal would be to keep our patients on long enough, either get that complete response or a good partial response, or that we could maybe turn the patient from a non-surgical into a surgical candidate.